Thank you, Dr. Naglia. Good morning, everyone. It is my pleasure to introduce this morning's speaker, Dr. Varun Aggarwal. Varun is an assistant professor in pediatric cardiology, and his areas of expertise is interventional cardiology. He joined our program 2 years ago after having completed a categorical fellowship in pediatric cardiology, followed by advanced fellowship in interventional cardiology, both at Texas Children's Hospital. Varun is a highly skilled interventional cardiologist, as well as an innovative and productive researcher. His research is focused on different aspects of novel catheter interventions. He is well published, has 59 peer-reviewed publications, 45 abstract presentations, and 3 book chapters, exceptional accomplishments for a clinically very busy junior faculty member. Dr. Aggarwal is also has been a selected member and awardee of several prestigious societies in his area of expertise, in particular the Society of Cardiovascular Angiography and Intervention. Varun will discuss today Pediatric Interventional Cardiology in 2021. Welcome, Varun.
Thank you, Emily, Dr. Neglia, and Dr. Steinberger. Thank you for that nice introduction. And good morning, everyone. I'll briefly run over what we do in the pediatric cath lab. And I don't have any financial relationships, but I will discuss some of the off-label use, because many of the products we use in the interventional cath lab in pediatrics, they're off-label. I promise I won't bore you guys with a lot of data. There would be very brief data, but we can discuss if people are more interested in data. This talk is more geared for general pediatric trainees as well as pediatric subspecialists, so that we can make you aware of what we do in our pediatric or congenital cardiac cath lab. So what I will be discussing today, or I'll be focusing on patent foramen ovale and atrial septal defect closures. I'll briefly talk about patent ductus arteriosus closure, including PDA closure in premature newborns. Then I'll briefly introduce you to ductal stenting for ductal dependent pulmonary blood flow, transcatheter valve replacements, especially pulmonary valve replacement, and show you some nice cases for vascular occlusions and stenosis that we have encountered. And I'll briefly show you one of the advances that we have started using for interventional imaging, including 3D rotational angiography and virtual reality. So please feel free to ask questions, put your questions in the chat box, and you can ask questions in between, happy to answer them, or at the end as well. We are all familiar with circulation, but I just wanted to bring this to highlight to the fact that the deoxygenated blood comes to the right side of the heart, goes to the lungs, gets the oxygenated blood, and then comes back to the left side of the heart. So the circulation is in series. So that's what we need to remember as pediatric training. So there is no mixing in normal adult human physiology of the deoxygenated and oxygenated blood. But this is not true for a fetus. When a fetus is in the maternal womb, there is no oxygenation happening in the lungs. The fetus is surrounded by amniotic fluid. There is no air going into the lungs. So the primary oxygenator is the placenta. And these 3 structures that are highlighted here in the box are the ones that help with this fetal circulation, namely the ductus venosus, carrying the umbilical venous blood to the inferior vena cava. And then the foramen ovale, which is the flap-like valve mechanism between the 2 atria, and it directs this oxygenated blood preferentially towards the left atrium. And then also the ductus arteriosus that directs the blood from the pulmonary artery into the aorta in fetal life. The reason I want to bring it up, because it's a nice segue to the congenital defects that we see in pediatric practice. And one of the most common lesions that is present after children are born is the patent foramen ovale, or abbreviated as PFO. As we saw, it's a remnant of fetal circulation, and it's basically like a flap valve mechanism. It's supposed to close in the first few weeks after birth, But in about 20 to 35% of healthy adults, it can remain open. And for most people, it's a benign finding. And especially in pediatrics, we consider it relatively benign. So what do we think when we see this, or if you have a patient and when to refer that patient for closure of this patent foramen ovale? The most convincing evidence to date has been for stroke prevention. There have been a number of studies which have been performed. The earlier studies that are highlighted in yellow here, they were underpowered or had older devices which were used to close these PFOs, and they did not show any significant benefit of closure of PFO to prevent stroke. But there are multiple new studies, multiple recent trials with large number of patients, which all of have shown significant reduction with PFO closure for secondary stroke prevention. And therefore, the patent foramen ovale closure is considered or is indicated in people who have secondary prevention of cryptogenic ischemic stroke. So if you had a ischemic stroke, documented ischemic stroke, and you don't find any other etiology or possible explanation, then we think that if you have a PFO, there may be a small thrombus which is present on the venous circulation, which potentially could go with increased intrathoracic pressure or Valsalva or maneuvers like that across the right atrium to the left atrium, and then went for systemic embolization, especially to the brain. For the similar hypothesis, people who have systemic embolization, which is idiopathic or cryptogenic, then that also becomes an indication for PFO closure. If you have platapnea, orthodeoxia, or in professional divers. One of the most controversial topic these days is migraine with aura. Currently, there is not enough evidence for us to say that we should close PFO in these patients. These are some of the devices that we use in the cardiac cath lab that is shown on the right here, including the Amplatzer devices and the Gore cardioform septal occluder. The basic physiology or the basic principle is that there is a small waist which goes across the small hole which is present in the patent foramen ovale, and then there are two discs on either side to capture the septum and to anchor the device in place. This is the true defect in the atrial septum when PFO is just a flap valve mechanism. But when there is a true defect in the septal formation, it leads to, it's called as atrial septal defect. The name of the atrial septal defect is just based on the anatomical location. If it's close to the superior or inferior vena cava, it's called as sinus venosus defect, because these embryologically, these structures are formed by the sinus horn of the venous structures. If it's close to the AV valve, it's called as ostium primum defect, which is basically a defect in the endocardial cushion. But what we are interested in as interventional cardiologists is this defect in the center of the atrial septum, which is called as the ostium secundum defect. And the reason we are interested in this is because, as I showed you earlier, similar to a PFO device, the ASD device, it has two discs on either side and then some waste in the center, which kind of fills the defect, so to speak. The mechanism, the only way we can anchor the device in place is if we capture the tissue of the atrial septum. So as shown in the picture on the right. So if the tissue is captured, if you have good rims around all around the defect, then only we can safely close the defect. What are the indications? So if you happen to have a patient in your practice and you're wondering when to refer this patient to a pediatric cardiologist or a surgeon or a pediatric interventional cardiologist, if anybody has any symptoms because of any heart disease, that's a no-brainer. You should refer that patient. If we happen to do a cardiac cath, as I'll show you in a little bit on one of our patients we did, and the amount of blood going to the right. So what happens when there is a atrial septal defect, the blood goes, the left atrial pressure is slightly higher than the right atrial pressure, and blood goes from the left atrium across the ASD into the right atrium. So it increases the blood going to the lungs, and that is denoted in our language as QP, or pulmonary blood flow, and QS is the systemic blood flow. So the ratio of the pulmonary to systemic blood flow is more than 1.5 to 1. Then it leads to right-sided cardiac enlargement, right atrial and right ventricular cardiac enlargement. And if we see that on echocardiogram, then it becomes an indication to close. Similar to a patent foramen ovale, it's not very common, fortunately, but if we see a paradoxical embolism in the absence of other causes, then it becomes an indication to close as well. But we don't want to refer all our patients to to the cath lab or even to the surgeons, because we know from natural history studies that some of these atrial septal defects, when they're present in small kids, they may become smaller or they may even close on their own, especially if the defect is less than 8 millimeters. So this bar chart, as it's shown on the left, if the defect is 8 to 10 millimeters or more, then the chances of spontaneous closure or spontaneous regression to less than 3 millimeter, which is probably not hemodynamically significant and could be tolerated very well, are low. So any defect which is less than 8 millimeter, it's fair to assume that it may get smaller over time, at least more than 50% of the times. So there are no limits, no lower age cut limit. So for this reason, many clinicians choose to refer asymptomatic children around 3 to 5 years of age, just to give them the best chance if the defect has to become smaller or close on its own. A small defect without evidence of any volume overload to the right side of the heart can be followed expectantly, keeping in mind that there is possibility of increase in shunt later in life. So you should not dismiss these patients if you are following them conservatively. We are all fortunate here. Some of you may have met Dr. Amplatz, who was one of the pioneers in making these devices. The Amplatzer atrial septal occluder is a device that I had shown earlier. It's basically two discs with a central base in the center. As you see, the disc on the left side goes first, and this is the right side of the heart. And then it comes on a screw mechanism. It's screwed on a cable, and once we are confirmed with the adequate deployment, the screw comes off and the catheter comes off. And it's a reasonable, fairly easy way to close the atrial septal defect if we have good rims. And this device has been in the market for more than 20 years. It got FDA approval in 2001. It's made of metal, which is called as nitinol. It's nickel and titanium alloy, and it's used because it has a self-memory properties. So irrespective of what shape you pull this device in, it has a tendency to go back to the shape it was designed to. So that way it has a capacity to go through a small catheter. And once it comes out of the catheter at body temperature, it would trend to express the shape that it was formed for. There is some data also suggesting that there is maybe a cost benefit to doing a transcatheter closure versus surgical closure as well. One of the major disadvantages of the previously shown Amplatzer device is a very, very low risk, 0.01 to 0.03% incidence of device eroding outside the heart, because it's a metal structure in the heart. And if it's touching any of the heart structures and the constant heartbeat, it can potentially erode. It's very low. It's about 1 to 3 in 1,000 patients who receive this device. So this is a newer device. It's called as Gore Cardiofarm Atrial Septal Occluder. It just recently got FDA approval in 2019, about 2 years ago. It's much softer. As you can see, there is more fabric. It's the patented Gore EPTFE membrane and nitinol wire, and it can be used to close defects up to 35 millimeter in diameter. It's much softer device. It comes with its own delivery system as shown in this animation. And then once the device is secure, it locks in place, you release the device, and it's supposed to endothelialize over time. And then after 6 months, if there is no residual defect, then you can space out their clinical follow-up. This is one of my patients. He's a 4-year-old, as you can see on the fluoroscopy. On the left, this is a sizing balloon. That's how we assess the size. We always use the transesophageal echo. As you can see, the transesophageal echo in the background on the fluoro here. And then the tip of the wire is in one of the pulmonary veins and left upper pulmonary vein in this case. And the sizing balloon, and you can see a small waist right here. And that's the size, that's where the atrial septum is. So this is the relatively large atrial septal defect. And this small child, you can see the size of the heart. And then this is after deployment of the Gore Cardiofarm atrial septal occluder. Once we were happy on echo as well as on fluoro, then we release the device, and this is how the device looks at the end. And then you see the separation on the two sides on fluoroscopy, and this is very important because this is where the atrial septum is captured. So a little bit of separation between the two left and right atrial disc is very reassuring. There's good data available in about published in 400 patients at a median age of 7 years with good outcomes after this device. One of the disadvantages of this device, it has a relatively stiff delivery catheter, and sometimes it becomes hard to align to the anatomy, especially in small patients with big defects. And we have shown that some modifications done in the cath lab using other delivery catheters and sheaths. For example, the Mullins sheath in this case can facilitate closure of big defects in small patients. Sometimes these patients are just too small. It's not more for the groin access. Sometimes the access is not there. You may have encountered some of the premature newborns with chronic lung disease or with some genetic syndromes who are in the NICU for first 6 months of their life, and they need multiple lines and catheters, and unfortunately sometimes we lose vascular access, or also because the heart is so small, expressing the disc on the left atrial side, aligning it parallel to the atrial septum during deployment can be difficult. And this is one of the patients that Dr. Saeed and I did recently, and we called it as hybrid ASD closure. So if you hear that term, it basically means that the surgeon and the interventionist, they're working together. In this case, we went, as you can see on this skin marking, we went from the right lateral thoracotomy. It was a small 1-inch incision or 2.5 centimeter incision. And these are the images which I stole from the echocardiogram performed by Dr. Bass that day. And as you can see here, the incision is small. This is the pericardium, which is retracted. And then you can see the beating heart inside here. This is the right upper chamber or the right atrium. And then Dr. Saeed did a purse-string suture, and then he gave us direct access into the right atrium. So once we had access into the right atrium, once we confirmed, we aspirated through the syringe, and then the guide wire goes in. And then it's all done under echo guidance. There is no fluoroscopy used. And then the guide wire is positioned across the atrial septum. Once we are happy with the guide wire position, the needle comes out, and then this is the sheath which goes in. As with many of our products that we use in pediatric interventional practice, you see these are the hand markings. We don't have any sheath that has graded markings. And so we just modify it so that we can guide ourselves how deep we are. So we had 1 centimeter marking up to 3 centimeters. This heart was only 2.5 centimeter combined diameter of both left and right atrium. And then the sheath goes in, and once we are happy with the position of the sheath in the left atrium, we remove the dilator is coming out, and then the guide wire will come out in a little bit. We aspirated the sheath, and then Dr. Saeed here secured the sheath so that the sheath is in place and it does not come out on us accidentally. Then the guide wire comes out after the sheath is secured, and then the device goes in through there. And as you can see, we access the right atrium. This was just using a forceps and seeing the direction of the needle puncture. And then this is how the device is going in the sheath right now. And this was the device post deployment. So we talked about patent foramen ovale, and we talked about atrial septal defect. As I showed in the fetal structures, one of the other remnant is patent ductus arteriosus. As you can see, it's a communication between the aorta and the pulmonary artery. So it again causes left to right shunting. The pressure in the aorta is higher than the pressure in the PA. It's about 1/3. The PA pressure is about 1/3 the aortic pressure. So it causes oxygenated blood to come from the aorta into the pulmonary artery. It goes back to the lungs and comes to the left side of the heart. So it causes left-sided cardiac enlargement. Indications for closure, again, as an atrial septal defect, if you have anybody with symptoms, it becomes an indication. If there is evidence of left-sided volume overload, then it becomes an indication. Premature infants with persistent PDA, I would say this is a very debated topic. It depends on the neonatal practice and neonatal preference as well. But in the interventional cardiology world, most of us would believe that if the PDA has remained open despite medical management beyond first 2 to 3 weeks of life, then we would think that it needs to be closed if it is hemodynamically significant. And then one of the debated topics is hemodynamically insignificant duct but audible PDA. Most of us would offer closure to these ducts because of the perceived risk of endocarditis. As with nature, the patent ductus arteriosus comes in varying morphology, varying shapes and sizes, and we have tried to classify to make our lives easier, so that we can talk in the same language. As you can see, it comes from A to E, and this F classification is the most recently described classification. As I'll talk in a little bit about premature, or it's called as the fetal ductus or the premature PDA. Because the PDA comes in various shapes and sizes, we have different shapes and sizes of devices which are commonly used for their closure. Implants, the duct occluder type 1 and type 2 are the FDA approved products. One of the commonly used product is implants of vascular plug, which is off-label use. And in children less than 2 kilograms, we have these two devices. One is FDA approved and the other is off-label, as depicted here. This is an example of a patient. This was a 2-year-old male who was referred for left-sided cardiac enlargement because of this hemodynamically significant ductus. As you can see, this is a frontal and lateral projection. This is a catheter in the descending aorta. And here is a conical ductus on frontal projection, and same thing on the lateral projection. And this is the pulmonary artery. We inject in the aorta, there is left to right shunt. So the contrast goes from the aorta into the pulmonary artery. This is the pulmonary valve here. There's a lot of left to right shunting. And then this patient underwent PDA closure using an implants duct occluder device, which you can see it's right in position, very well seen on the lateral projection here. And then there's a trivial residual shunt across the device. This was immediately after deployment, and on the echo, a couple of hours later, there was no residual shunt across the device. Our devices available to us have recently, I think it was also 2 years ago, that this Abbott Piccolo device was approved by the FDA for use in children as small as 700 grams. As I showed in the previous slide, the PDA present in these premature babies is usually long and have a hockey stick appearance, and this has been described as a fetal type ductus or type F ductus. These are the two most commonly used devices. Of course, one is FDA approved and the other one is used off-label. It's a microvascular plug, Medtronic microvascular plug. This is an example of one of my patients who was X22 weaker with a birth weight of 406 grams. He was referred at the age of 1 month. He was weighed around 900 grams. He was on high frequency oscillator ventilator at that time. And as you can see on the echo, there was significant left-sided cardiac enlargement as compared to the right side. One of the concerns in these small babies is their vessels are small, and if we go into the artery, in the femoral artery, we can cause femoral arterial injury, which can have very bad consequences. So we have tried to do these, most of the places in the country have tried to do these closures without any arterial access in these small babies. So it's just venous access and mostly echo guided. We do take one angiogram to make sure our catheter and measure the ductus arteriosus as seen here. This is the catheter going across the right atrium. This is a lateral projection. So right ventricle pulmonary artery. This is the area of the pulmonary valve. And then here is the ductus coming at the roof of the left pulmonary artery. And these are the branch pulmonary arteries going. And then we inject contrast, and there is wash-in because the aortic pressure is high. So the contrast doesn't fill the aorta. And the wire is across the ductus into the descending aorta. This was the same patient after placement of one of the Abbott Piccolo devices. And as you can see, this is an echocardiographic projection. This is the device, the Echo Bright device in the center. There's no residual ductus. This is the descending aorta here on the right. And then this is the left pulmonary artery that we are concerned that sometimes the device can cause occlusion. So we are always very careful and look at the left pulmonary artery. As somebody told me, you either close the defects that are there or you keep them open. So we actually do that. This is the PDA, sometimes in babies with complex or critical congenital heart disease, as shown here in tetralogy of Fellow. There is right ventricle outflow tract obstruction or a narrowed pulmonary valve as shown in this case. So there is decreased pulmonary blood flow. So these patients either undergo a neonatal repair, or if for some reason neonatal repair is not considered appropriate or adequate and we want to wait for a few months, then they need some alternate source of pulmonary blood flow. And this alternate source of pulmonary blood flow, as conventionally being provided by a surgery, which is either a classic BT shunt in which the subclavian artery was disconnected and connected to the right pulmonary artery. And nowadays we don't do that, and we preserve the flow to the right arm, and the surgeons place a Gore-Tex tube graft or a saphenous vein graft from the right innominate artery, right subclavian artery to the right pulmonary artery. But these patients already have a PDA, right? They already have a connection between the aorta and the pulmonary artery. So one of the ways to just to keep it open, we sometimes keep them on prostaglandin till they undergo a procedure, and that's medically keeping it open. Or you can stent this ductus and avoid a cardiac surgery in these critically sick newborns. This is an example of a patient that we did a few months ago. She was 8 days old and 3.7 kilograms, born with pulmonary atresia. As you can see, she had valvular pulmonary atresia. So if I can stop it right here. We do unconventional access. So it's not all the access is through the femoral artery. And in this case, as you can see, we went from the right common carotid artery. The sheath is coming here from the neck and right common carotid artery. And then this is the PDA. This is the right pulmonary artery, left pulmonary artery, and this is the main pulmonary artery. And as you can see, there is no flow coming from the MPA. There was valvular pulmonary atresia. So this child was dependent on prostaglandin, and she is actually 4 months old now, has not needed any subsequent procedures, has been thriving reasonably well, and scheduled for Glenn operation in the next 2 weeks. So she was able to save a cardiac surgery with this procedure. There has been an ample amount of literature. I would not bore you here with all the literature that is there, but just wanted to show you briefly. If you look at the literature from United Kingdom, which is through a national registry from all the patients that have undergone these procedures, there's a survival benefit for these ductal stent as compared to the same patients receiving BT shunt. Some of the multi-center collaborations from the United States show that there may be equal mortality and unplanned reinterventions, but there is unconvincing. There is a lot of data that the morbidity is much lower if you do the ductal stent as compared to a surgical shunt. Length of hospital stay, length of ICU stay, and ventilation, everything is lower. And this is one of the review articles that again summarizes everything. If anybody is interested in reading more, it just demonstrates that there is comparable mortality, shortened morbidity, and hospital length of stay and ICU length of stay. And nowadays we have newer stents which elute drugs, and it help reduce the rate of unplanned reinterventions or intimal proliferation inside these stents, needing reintervention for cyanosis. So after dealing with these babies, when they get ductal stent or BT shunt, they undergo surgical repair for their tetralogy of Fallot, which is in the form of a transannular patch, which basically means across the pulmonary valve annulus, there is an incision made by the surgeon, and then there is a patch placed to relieve that obstruction and make the annulus bigger. One of the downsides is these patients develop a pulmonary valve insufficiency, which is tolerated very well for many years, but as they grow older, some in the first or second, late first decade or early second decade of life, these patients need a competent pulmonary valve. We do have the advancements now to provide pulmonary valve replacement in these patients, just close approach from the groin and avoiding a cardiac surgery. If anybody is interested in history, this is one of the book chapters from American College of Cardiology, and it's a transcatheter heart valve book. And as you can see, the first investigational use of first FDA approval for Melody valve was in United States was in 2010. So now we have almost 11 years experience of use of this valve in congenital heart disease patients. And we have newer and newer valves and technologies that are coming to our use. And Sapien S3 valve is the most recently FDA approved valve. I'll show you a couple of examples here. This is a patient, a 22-year-old gentleman who was born with congenital heart disease, specifically severe aortic valve stenosis, and he underwent balloon aortic valvuloplasty as a newborn. It was tried to repair. It was tried to be repaired surgically. It didn't work out. So what the surgeons do is called as a Ross procedure. They take the pulmonary valve, put it in the aortic position, so that it can work in the aortic position, and then in the pulmonary position they place the RV to PA conduit. He unfortunately developed RV to PA conduit stenosis, and then he underwent a conduit stent and Melody valve implantation. He, as you can see in the picture on this center screen, he developed multiple stent fractures. There are a lot of things that are related. The interaction with the surrounding structures is probably one of the most important things that I care about in the interventional cath lab. These conduits, they are very rigid, they become calcified over time. And since they're very anterior structures, sometimes they are just behind the sternum, and the constant heart beating action and the aorta from the behind, it's the pressure between the two structures. It can actually make even these metal stents crack and fracture. And as you can see, there are multiple fractures in this stent, and it led to disintegrity of this Melody valve that was placed. He had severe obstruction across this Melody valve. His RV pressure was almost systemic pressure. It should be less, about 1/3 systemic. So he came to the cath lab, and he underwent conduit angioplasty of this previous stent. We placed a new stent inside the previous stents, and he got a new Melody valve. Now he has an unobstructed right ventricle outflow tract. He's about, I think, a little less than a year ago, and he has been doing great after the valve placement. The other spectrum of disease is the patients that I was talking to you about is tetralogy of Fallot, who get a transannular patch. Now, they don't have a RV to PA conduit or a surgical conduit or a pulmonary homograph, but this is their native tissue, but it's a very expansile structure. And as you can see here on the angiogram of the left, this is a catheter going from the femoral vein across the right atrium, right ventricle, and across the pulmonary valve into the left pulmonary artery. And then the contrast injection, it shows free pulmonary valve insufficiency. Contrast just flows to and back into the main pulmonary artery. And this girl was symptomatic because of this progressive pulmonary valve insufficiency. As I mentioned in the previous slide, the interaction with the surrounding structures is probably one of the most important things that we have to be concerned about in the interventional cath lab. And what we do is called as the balloon testing. We inflate a balloon of the intended size of the valve, and then we test for like coronary arteries if they are closed. And in this case, the coronary compression testing was inconclusive. We were not sure if the stented valve would cause compression of this left coronary artery in this case. So we have now the capacity of doing what is called as 3D rotational angiography. So we inject and we rotate our C-arm in like 270 degrees. So it gives you a nice immediate 3D reconstruction. So the balloon was inflated in the right ventricle outflow tract. And then we saw the interaction of this coronary artery. And you see this left coronary artery, there was still a decent amount of space despite the balloon being inflated. And we felt comfortable with implantation of the Sapien S3 valve in this 23 kilogram, relatively young patient. And she had a competent valve, and we did test for coronary circulation after the valve placement. And as we predicted from the 3D rotational angiography, she had good coronary flow to the left coronary artery. Size does matter in these patients. The biggest valve that we had till recently was available for patients with an annular diameter of about 29 or 3 centimeters or 29 millimeters. But sometimes many of these patients, they may not be candidates for the valves that are available to us till most recently. This is a fresh FDA approval about a month ago. It's called as Medtronic Harmony valve. Hopefully we'll get it for our patients as well. This is a self-expanding valve made of similar metal as the Implanzer atrial septal defect. It's made of nitinol. It's a self-expanding property. It's not dependent on balloon expanding properties it's not a balloon expandable valve like the Melody or the Edward Sapien valve. As you can see, it's a delivery mechanism. You have to load it inside this catheter, and then once you are in good position, you just expose the valve out of the sheath, and then the self-expanding properties of the nitinol, the valve expands in place and anchors itself just because of its size properties. And then it can be used, as you can see on the anatomic size chart here. There are 2 currently available FDA-approved sizes that are available for much bigger size than 3 centimeters that we were currently restricted to. Some of the case examples, any vessel, any vessel that you can imagine in the body, there can be problems associated with it, be it systemic veins, pulmonary arteries, in the coarctation, in single ventricle palliation pathways, in the Fontaine conduits, cavopulmonary anastomosis. Sometimes we have been involved in patients even outside the heart, like in liver disease patients with ductus venosus, and in peripheral arteries and veins. This is an example of a patient. As you can see on the angiogram on the left here, you see all these stents, three stents, three right-sided veins, all were stenotic in this patient. So stents in three right upper, right middle, and right lower pulmonary vein. This is a stent in the left upper pulmonary vein, and he had complete atresia of the left lower pulmonary vein. As you can see, there is a small beak, but there is no communication with the pulmonary vein. Fortunately for this patient, we were able to recanalize this and pass a wire, and then you can see a stent in the pulmonary vein. So, so this can be possible, but it takes time and energy and commitment as a care team. Similarly, this was a young gentleman who was referred for vascular access. He unfortunately had Crohn's disease and severe Crohn's disease, short gut syndrome, and he was dependent on TPN. In his 22 years of life, he had exhausted all vascular occlusions. As you can see, the right innominate and subclavian artery is completely occluded. SVC was completely occluded. The flow that you see is just through some venous collaterals. This is not the SVC flow. And then even the right left in the left innominate vein and subclavian vein are occluded. This was 10 hours and 8 stents later. We were able to recanalize the both the subclavian veins, the jugular vein, as well as the SVC. There are multiple overlapping stents here in the SVC. This was a case we recently had, and I have to acknowledge the contribution of the other care team providers. We work as a group. We can't work in isolation. Dr. Nick Brown from the intensive care unit was the one who reached out to us and said, I think we can do something here for this 1-month-old child who had trisomy 21 and severe portal hypertension because of congenital hepatic fibrosis. It was so bad. I don't think I've ever seen this, but upper gastrointestinal bleed on day of life 2. And recurrent upper GI bleed, refractory medical ascites because of portal hypertension. Fortunately for us, he still had this ductus venosus that we could see on the ultrasound and even on the echocardiograms. And this is the portal sinus. As you can see, there was about 9-10 millimeter mercury mean gradient across this structure. So significant portal hypertension. And Steffi, who is one of the residents, she's actually presenting this case as an oral presentation later this week at one of the international conference of the Society of Cardiovascular Angiography and Interventions. This was the CT of the same patient. As you can see, this is the portal sinus and the ductus venosus on the 3D reconstruction on the right. And we went in from the right internal jugular vein, and you can see this is the portal sinus. These are all the portal veins in the liver, and the ductus venosus is just as big as the catheter. It's about 1.3, 1.4 millimeter diameter. So we were able to angioplasty it successfully, and then place a 5 millimeter stent, resolute onyx stent. There was good flow through the stent and decompression of portal vein to the inferior vena cava. I have seen this child in follow-up. The last follow-up was at the age of 8 months. The stent has remained patent, and I was actually astonished. His ascites has never recurred. He had no more episodes of upper GI bleed, and he is thriving well at home and has done very well. Imaging is critical to what we do. Surrounding relationship to surrounding structures, how the intended intervention can cause compression or distortion of the tissues. So 3D prints using 3D visualization technology like EcoPixel or virtual reality softwares like this one that I'm showing here on the right. But this takes a lot of collaboration, and if you haven't heard, you should go to the Visible Heart Lab webpage run by Dr. Lizo and Dr. Isles on the East Bank, and they have been an immense resource for us for helping understand the anatomy for some of these complex patients. because as you can see, this patient had a very tortuous ductus arteriosus that was coming from the side of the descending aorta. And then it was, here is the ductus arteriosus coming from the side, and it was going, and there was complete pulmonary atresia. So things will improve, but these imaging technology is something that makes our job much easier. And nowadays we are also working with their team on computational fluid dynamics, and Dr. Narasimha is working very, helping us working on that as well, and understand how different anatomical obstructions cause pressure loss, so to speak, or energy dynamics in these patients with congenital heart disease. It takes a team, as I said. I cannot finish this talk without acknowledging my mentors who have trained me. Dr. Mullins, who had the opportunity, who is one of the fathers of interventional pediatric cardiology, had the opportunity to had first hand-on experience discussing cases with him. Dr. Qureshi and Justino, who were my mentors and mentor me to till date. And thank you again, Dr. Steinberger, Dr. Bass, and Dr. Neglia, Emily, for giving this opportunity. I can take any questions if anybody has any questions.
All right. Yeah, feel free to put in questions in the chat or in the Q&A. I wrote it down, said remember to ask you. This one comes up a lot. And before Grand Rounds, I asked a question, and Dr. Neglia asked if I was studying for my boards. And I said, I don't have to take boards anymore. So every question I ask is to help me take better care of patients. When we get an echo, the most common scenario is newborn nursery. There's a murmur. We get an echo. It says PFO. Yes. So would it be described differently if it was truly an ASD versus a PFO? And does that have any ramifications for how likely it is to close?
Yes, very good point, Emily. And our Echo Lab is great at describing this, and I would believe that you can trust their judgment. Basically, what as I tried to show, what a PFO is, it's basically a flap valve mechanism. So if you see a flap valve mechanism, it makes it more reassuring than that this is a PFO. If you don't see a flap valve mechanism, then there are two possibilities. Either there is cardiac enlargement for some reason, and when there is cardiac enlargement, this flap valve mechanism, which was supposed to be flap valve, it's got separated a little bit, and now we describe it as stretched patent foraminal valve. And in my mind, it's very hard to differentiate that from a true atrial septal defect sometimes. So, or a small atrial septal defect. So that sometimes in my practice, if I'm doubtful, I don't dismiss them straight off my practice. If it's a straight flap valve mechanism, I reassure the family. But if I don't see a straight and it may be a small atrial septal defect, then in my mind, it's okay to see them maybe at a year of, it won't cause any immediate harm, but you don't want to dismiss these patients that they don't have any defect and they may have problems later on. So it would be reasonable to see them at 1 or 2 years of life and get another echo at that time and reevaluate.
Thank you. That's helpful. Yeah, I mean, I think the stroke risk data for PFOs is fairly compelling. So it seems that probably anyone who has either a PFO or an ASD has bought themselves an additional echo at some point in their small childhood. What's your success rate with the squirminess of children? Like, is 2 years old preferred, 3 years old? If they're 18 months and they're having a tantrum, are they just going to have to come back again? What are some of the features that might suggest, yeah, this one needs closer follow-up? Some of the maybe other findings on the echo?
Yeah, no, terrible twos is not a good time to do an echo. 45 minutes echo, it's boring. But definitely, like if it needs to be done, we can give a little bit of sedation and do an evaluation. But most children, they are cooperative. Our sonographers are excellent, and that's what they do every day. So and they're able to get us very good, reliable pictures, and the echo lab is amazing. So it also depends on your team. So the team here is excellent. So if you have a patient, if you have confusions, then getting an echo, I would not say you have to restrict yourself from referring to a patient just because of the age, and it may be hard to get a study. Um, but there is no age cutoff per se. Fortunately, most of these strokes, they don't happen in pediatric population for us. And these are cryptogenic strokes that happen in adults. But if there is somebody who has a PFO and idiopathic stroke, then yes, that becomes a current recommendation to close it.
Okay, thank you. This question is not about cardiology explicitly, but someone is wondering, what role did mentors play in your training and career?
Mentorship, as I try to highlight some of my mentors, everybody is a mentor. When I go to the echo lab, the echo doc becomes a mentor. But I don't think we can be a successful clinicians or even a researcher without a good mentorship. The mentorship is very critical, and it's a mentor-mentee relationship. It's not a one-way stream. You have to be respectful of the time of your mentor, and you have to do for the trainees in the group. You have to do your part first before you ask for time from your mentor. At least in my mind. And don't hesitate to ask questions. Don't hesitate to reach out if you have questions and if you don't find answers. But also do your due diligence, do your research, and try to find answers to the questions. But if you don't find, then I think nobody can progress without a good mentor.
Great, thank you. This one is about people who are getting close to the edge of pediatric age. Thank you so much for this brilliant presentation. I was wondering about transition of care for your patients that may need future adult surgeries. How do you decide when to transition to adult interventional care? Just wondering because of the 22-year-old male with severe aortic stenosis that you mentioned during the presentation.
Yes, this is a very good topic, and probably one of the most asked questions in the pediatric world. How do we transition care? So that's why you may have seen some of us have started writing ourselves as congenital interventional cardiologists rather than pediatric interventional cardiologists, and for good reasons, and I can tell you why. These diseases or transcatheter pulmonary valve replacement, it's not something that is done on the adult side commonly. They do transcatheter aortic valve replacement much more commonly than we do because aortic valve derangement in older people. But transcatheter pulmonary valve replacement is not one of their strengths. It's one of our strengths. So that's why a close collaboration with the adult congenital team is very critical to help us in the care of these patients. And many of the pediatric interventional cardiologists in our training, we have done enough work on this. Some people call it grown-up congenital heart disease or Gucci or adult congenital heart disease, that we feel very comfortable in interventional cath lab on these patients. But without the ACHD team, we cannot function in the care of these patients. And as with anything, it's a care team. You have to have a good team with yourself if you have to be successful in providing good care. So this was a patient who is cared for here for many years, for the last 22 years essentially of his life, and he's still followed with our practice for these reasons. And he still was brought to the pediatric cath lab, so to speak, or you can say it's the congenital cath lab.
Wonderful. Okay, this question comes from Dr. Lohr. She wants to thank you for the shout out for the adult congenital heart disease team. Is there a role for TAVR as a first procedure in young adults with BAV and normal aorta?
These are excellent questions, and and I am biased.
Could
So,
you just remind us what those abbreviations stand for?
oh yes, sorry. So Dr. Lore is trying to ask, is there a role for TAVR? TAVR is transcatheter aortic valve replacement. Is there a role for transcatheter aortic valve replacement as a procedure in young adults with bicuspid aortic valve and normal aorta? BAV is bicuspid aortic valve. This is how medicine progresses. If we are interested, a brief history of how the transcatheter aortic valve started. For some of the old frail patients, people or the cardiac surgeons were afraid to take them to the operating room to do a surgical aortic valve replacement for good reasons, because they are not good surgical candidates with a very high morbidity and mortality. So that's how the transcatheter aortic valve replacement program started in adult population. Over time, data on thousands and thousands of patients showed that it may be comparable to surgical aortic valve replacement, or some of the most recent data shows that it may be better in terms of their morbidity and mortality outcomes, even long term, to do a transcatheter aortic valve replacement. Over time, as the technology advanced and evolved, the transcatheter aortic valve replacement is now even offered in low-risk adult patients with aortic valve disease. Again, bicuspid aortic valve is a trickier population. It's a relatively difficult technically in a bicuspid aortic valve. But these patients, they also have calcified aortic annulus, calcified valves, and stenosis, so they can anchor a valve. I hope in future there will be a transcatheter aortic valve technology for children, and I think maybe it should be coming in the future, because we have the technology and we have the capacity to do it. But when do we cross that line, and does it need a randomized controlled trial? Does it need a study before we say that we are deviating from the standard of care, which is surgical aortic valve replacement in these patients?
Wonderful. Thank you so much. And for there's a lot of lingo in your field that I have maybe once known and now forgotten. I guess it looked like maybe one of the, or probably more than one of the studies that you showed, you were a co-author on like using a different sheath for deploying the ASC devices. Can you talk a little bit about how you go about studying something that already has one sort of approved way of doing it, and then you're trying to make a modification to how to do that procedure?
Yes, that's a good point. That's probably what we do every day, Emily, in the pediatric cath lab. And some of these questions have been asked to us, not so remotely, because there is an approved indication for a device, and you would imagine like there's so many patients with pulmonary artery stenosis, and they get pulmonary artery stents, but none of these stents, they have FDA approved indication for this use. So we use many products that we use in pediatric cath lab is off-label use, unfortunately. And same thing happens for this GORE. So the GORE implied atrial septal defect occluder device is FDA approved. But just because of the stiffness of the delivery catheter, we cannot align the device properly. So instead of using a short sheath in the groin, it was actually one of my mentors that I showed you the picture, Dr. Athar Qureshi. To his credit, he came up with this idea. If I use this curved sheath, I may be able to align the device parallel to the atrial septum, and it worked. So, and then he used it, and we published our experience on about 52 patients. And we have shown that if it's not possible the routine way, if you use these slight modifications, some people have used other delivery sheets, some people have hand modified the delivery catheter to give it a little bit of curve to align to the anatomy. Because as you can imagine, these devices, they're approved for pediatric patients, but they're not approved for the smallest and smallest of the patient that we see in our practice, and every child's anatomy is different. So these modifications are not uncommon for us to do. Of course, it's all off-label use of the devices when it comes to that.
How often do you have I have lots of questions for you, so if they don't come into the chat, but it seems like there's a lot of that, like how you were like marking on the thing with a whatever, probably wasn't a Sharpie, but like some kind of marking of like 1 centimeter, 3 centimeter. Do you have back and forth with these device makers to say like, gosh, it would be great if your thing had this feature, or do you work with our device center at the university ever, or?
Yes, I did not present, but there was an interventional cardiologist from Europe who presented at one of the national conference last year at it's called as Pediatric and Adult Interventional Cardiology Symposium, or PICS, as many of us know. And he presented a prototype of a sheath which has inbuilt markings, and it was a Shark Tank, so to speak, in the conference, and they were offering money for people who would come up with great ideas to come as a like a pilot money to give the head start to their project. I think he got the money, and hopefully he'll come up with that device. But the main problem with us in pediatric practice and in pediatric cardiology is industry is not very interested, because in the country, there would be maybe 200, 300, 500 of these devices would be used every year, which does not make sense for them to invest millions or billions of dollars in the R&D and FDA approval for these devices. So that's where the limitation comes. So we as pediatricians and pediatric cardiologists have to lobby for our patients that even if it does not make financial sense, it makes total sense for the care of these patients.
Yeah, that's a really important point, that the number of cases and trying to get investment from the companies that may have other devices that make them more money.
Yes.
Well,
I have had discussions with companies,
yeah.
and the first thing they ask is, what is the market?
Yeah.
And if we invest $5 billion here, what are we getting out
right.
of it? And it's just the nature of the beast. So.
Well, thank you so much. That was just such an excellent overview, and I think really helped us all to get a good sense of the wide scope of practice in pediatric interventional cardiology and what's possible now and what might be possible in the future. So thank you for a wonderful talk. Have a great Wednesday, everyone.
Thank you.
Bye.